العراق موجود؟ تفضل يا دكتور مثنى. والدكتور هاني عبد الهادي. هاني انت ماخذ كل السيشنز، شو قصتك امبارح واليوم واخر الجلسه؟ دكتور عاصم بلعاوي. دكتور حسين. دكتور رازي من الخدمات اعتذر انه يجي الصبحيات، عنده حاله. دكتور كابينسكي. الدكتور وائل. دكتور وائل رئيس جمعية القلب التداخلية السعودية. طبعا السنة هذه عاملين سبورت قوي جدا للجوردن وللمؤتمر. تفضل. مين بده ولا هاي؟ عبد الحكيم دية.
Right, so hello? Is it working? Very good. Okay, should we start the session? Okay, thank you very much. So can we have our first speaker? We have Dr. Abdel-Hakeem Dayeh, the future of minimally invasive valve surgery. Very exciting work.
طيب صباح الخير. Good morning. Thank you for coming so early. The only surgical presentation today will be about minimally invasive valve surgery, or the future of the minimally invasive surgery. In the last decade or 5 years, we saw very fast growing minimally invasive technique due to the expected reasons of the surgery. It's the patient desire mainly, the less complication, the cosmetic aspects, and the less ICU stay, less bleeding, all less complication. If we look at the aortic valve, we shifted from the classical approach with the sternotomy at first to the mini sternotomy, small incision in the middle of the sternum with a small cut of the sternum. After that, we shifted to the called mini right anterior thoracotomy with a small incision at the right side. This technique is now our standard approach to treat the aortic valve and to make the aortic valve replacement, aortic valve surgery. Almost about 90% of our cases will be done in this technique. As you see in the picture at the right side here, this is the aortic valve, very visible, very easy to see in the minimally invasive technique without any limitation. As you see here, this in this small video, that is the hole we use to access the aortic valve, is sometimes as big as the valve itself. If we look at the cosmetic result here, some picture of the patient after surgery, we have two approaches. One is more lateral. One is more lateral, as you see here in this patient, and the other one is more in the median, more near to the sternum. The data, as we expect, are excellent. The biggest group who make a study about the minimal invasive aortic valve are the Boston group with excellent results. Also the Bristol group make a systemic review about the minimal invasive aortic valve with also excellent result, less ICU stay, less everything, better cosmetic results. The mitral valve is now already the standard, the minimally invasive is the standard approach to treat the mitral valve. It's the part of the minimally invasive versus sternotomy in the whole world is expanding very fast. In Germany, almost all of the cases for aortic mitral valve will be done in the minimally invasive technique. If you don't make minimally invasive mitral valve, you don't get any patients from the cardiologist. We in Jordan do almost all of our cases, almost more than 95% mitral valve surgery, isolated mitral valve surgery in minimally invasive approach. Sometimes we become the question, if you have a complex mitral valve, do you still do it in minimally invasive technique? I say, yes, sure. It's an example. This patient have a very severe MR, as you see in the echo, with the ruptured chordae at the anterior and at the posterior leaflet, very severe MR, very destroyed mitral valve. So, offshore we do this patient in minimally invasive technique and we repair the valve, and that is the result, very small incision, very nice repaired valve without any risk of regurgitation, and the cosmetic result you can see is also very satisfied for the patient. The studies are well known about the mitral valve. The mitral valve is now the standard approach due to the excellent data and result we've seen in the last 2 decades. But now in the last I see 5 years, the minimally invasive technique became also visible in very complex surgeries, tricuspid valve and redo valve surgery. The redo surgery in the cardiac surgery is a big chapter and it's complex due to the reason of adhesions and risk of injury of the valve, but we cannot imagine that we can do this procedure in minimally invasive technique. We have 2 valves, the mitral valve and the tricuspid valve can be done now in minimally invasive technique. Here is one of our patients with very severe TR, very sick patient, 20 years after mechanical mitral and aortic valve. We have a lot of this patient in our region due to the rheumatic disease in early ages and developing of very severe TR in the, after that. The patient almost come very late to us with ascites, renal impairment, right side heart failure. And can you imagine how difficult will be this surgery if we do it in standard approach, sternotomy and reduce sternotomy and make the adhesions and all of that things. We do this patient in a very nice technique, beating heart on the bypass machine, cardiopulmonary bypass, beating heart, tricuspid valve surgery. We open the right chest, as you see here. We open the right chest. We direct access to the tricuspid valve and make the procedure. As you see, the tricuspid valve repair with the placement of the ring. And you close the right atrium and the procedure is finished. You don't need to do anything else. The patient will recover very fast in beating heart. There are no ischemia, no anything. The other thing is the mitral valve. You know the mitral valve is in the left side of the heart. That means you have, it's different than the tricuspid valve in the right heart. So we have to make the heart fibrillating. We put the heart at the cardiopulmonary bypass and make the heart fibrillating. After that, we access the heart through the right side and open the left atrium and make the surgery. As you see here, with this lady which have stuck mechanical mitral valve and have severe tricuspid regurg also. We do that in fibrillating heart, access the mitral valve, open the left atrium, access the mitral valve, replace the valve, repair of the tricuspid valve. As you see the fibrillating of the heart of the monitor, it's not so clear. And after that, repair of the tricuspid valve on beating heart. Can you imagine that this patient have only 150 milliliter in the chest tube after 24 hours of the surgery? If you imagine if you do this surgery in the classic approach and you make a sternotomy, redo surgery, open the chest again, and make all of the adhesions with the patient on warfarin and stacked mitral valve, how can you imagine how much is the bleeding loss by this patient? The last one case what I want to present is to see how advanced is the minimally invasive technique. Here is a very complex case of a really very complex Hussam patient with SAM and resulting very severe MR, very symptomatic patient, which she refused any kind of sternotomy or classical surgery come from abroad. Also this patient, we did in the minimally invasive approach, small incision with a very satisfied result, massive myectomy. So that is it. As you can imagine, the minimally invasive surgery become feasible and doable also in the complex cases, redo double valve, Hussam, all of this very complex valve surgeries. In the mitral valve, we are now in the era which is the standard approach for the mitral valve surgery, no need for sternotomy. But the aortic valve become also more and more the standard approach in our practice in this very competitive time with the TAVI era. Thank you very much.
Thank you very much, Dr. Abdel-Hakeem, for this nice presentation.
Shall we postpone? Thank you. Yeah. Thank you very much for the presentation. Beautiful talk. So, as a humble cardiologist who needs to refer somebody for cardiac surgery afterwards, I'm very sorry. I need to ask you very important questions afterwards. It's a very interesting topic.
Our next speaker, Dr. Hussam Suradi, he will be presenting life-saving LAMPOON for critical bioprosthetic mitral valve stenosis.
Right. Good morning, everyone. Thank you for the organizing committee for the kind invitation. It's a great pleasure to be here again this year in my hometown. I'm going to follow this great presentation that Dr. Abu Dayeh had given, and I'm going to present a challenging case of a patient who had a critical problem with her mitral valve prosthesis. Just a little bit of background on this patient. She's a 44-year-old female with intellectual impairment and has no family support. She resides in an assisted living facility. She didn't have really a great medical care over the years. She has past medical history of mitral stenosis where she had a bioprosthetic 25 millimeter Hancock mitral valve replacement and ASD patch repaired in 2000. She has history of AFib, hypertension, hyperlipidemia, as well as I mentioned, she has some intellectual delay as well as a hypothyroidism. She presented to an outside hospital emergency room due to complaints of shortness of breath and peripheral edema that has been going from the history that obtained about at least 10 days prior to that. She was found to have critical stenosis involving the prosthetic mitral valve, so she was transferred to our university hospital in downtown Chicago. Upon presentation, she was hypotensive, hypoxic, clearly volume overloaded with crackles, elevated JVP, and basically anasarca picture with ascites and peripheral edema. So obviously she had a transthoracic echo, and as you can see, she had a huge dilated right ventricle with a small squished left ventricle. You see the flattening of the interventricular symptom suggestive of RV pressure overload. And this is our four-chamber view, again showing severely dilated. Let me see if I can play this again. Severely dilated right ventricle, severe dysfunction. with a mean gradient of 25 millimeters mercury across the mitral valve. This is one of the highest gradients I've ever seen across the mitral valve. There was also severe tricuspid regurgitation with severe pulmonary hypertension. The RVSP estimated more than 60 millimeters mercury. She was clearly in multi-organ failure. She was in acute renal failure as well as liver failure. Her INR was 1.8. She was hypoperfusing with elevated lactate level of 4.7. As a standard approach to any patient who is in kind of shock picture, we have a low threshold to proceed with hemodynamic assessment with Swan-Ganz catheter, and you can see the measurements here. She had severely elevated right-sided pressures with at least moderately elevated wedge pressure. Her cardiac index was severely low, and at that time her aortic pressure was in the 100 range systolic. So this is a patient with severe prosthetic mitral stenosis. She has severe pulmonary hypertension. She has multi-organ failure with liver, renal failure. She was not making any urine. She was clearly overloaded. We started her on renal replacement therapy. She rapidly deteriorated after that, became very hypertensive. She had needed increasing pressure support, so she was placed emergently on a peripheral VA ECMO. She was seen by our cardiac surgery team, and she was deemed not a surgical candidate due to clearly cardiogenic shock, multi-organ failure, hemodynamic instability. So after discussion with our heart team members, we decided to proceed with transseptal mitral valve and valve implantation. So transseptal mitral valve and valve, what it involves basically is a transvenous approach. We get access into the femoral venous, and then following that we obtain a transseptal puncture. We dilate the interatrial septum with a balloon. Then this would facilitate the delivery of the transcatheter heart valve delivery catheter, where we then follow with implantation of the percutaneous valve. And this is a quick animation of how this is done. So this is, we're already across the interatrial septum here, and this is the, typically we use an Edwards valve for these cases, where you can position it across the mitral valve, and then we inflate the balloon and the valve is deployed. One of the most dreadful complication of these cases, the transcatheter mitral valve replacement, is the risk of obstructing the left ventricular outflow tract. So if you can see here, what happens is the anterior leaflet of the mitral valve lies very close to the LVOT. And if a valve is placed in the mitral position, this can potentially push the anterior leaflet towards the LVOT and cause an LVOT obstruction. This is a pretty lethal complication with mortality more than 50%. Luckily, it's not that common with valve-in-valve procedures. It's less than 2%. It's more common if we do this procedure in valve in MAC, mitral annular calcification cases. And generally, we screen these patients. All these patients get CT, and we can get some predictors of which patients are gonna develop this LVOT obstruction. And one of these is on CT. We place a virtual valve within the mitral valve prosthesis, and then we measure what's the LVOT area. It's something we call a neo-LVOT. And if this area comes back small, the cutoff is usually less than 200 meters squared. This tells us this is a high risk for LVOT obstruction. Another predictor on CT is the aortomitral angle. So the more the obtuse the angle, the less the chance of LVOT obstruction, as you can see. So going back to our patient, so we obtained the CT on her to assess, her anatomy, and clearly she did have a very small LVOT on the right side of the screen. Here is basically our virtual valve, and this is the area which is traced. This is the neo LVOT, and we got an area of 160 millimeters squared. Remember, less than 200 millimeters squared, this is a high risk for LVOT obstruction. And you can get a sense of it by looking on transthoracic echo. You can see the valve strut is so close to the interventricular septum. Again, the diameter was about 3.4 from a virtually implanted mitral valve. So how can we prevent the risk of LVOT? In general, there are two ways. One of them is what we call septal reduction strategy, which basically means reducing the width of the septum, interventricular septum. And generally, we do this with what we call alcohol septal ablation. This is what we do in patients with hypertrophic cardiomyopathy, where we inject alcohol into the septal branch to ablate it, and this will basically kill the cause atrophy of the tissue there. However, the results are less predictable, and it can take at least several months to get really the results that we wish for. One of the new innovations to prevent the LVOT obstruction is the LAMPOON technique, which I'm going to talk more about now. So this is the animation of the LAMPOON, and this is the classical LAMPOON. So what it is, basically, we insert two catheters from the aortic valve, and then we insert a snare from the left ventricle into the left atrium. And here you can see we advance an electrified wire through the mitral anterior leaflet. And once this wire is electrified, we basically split the anterior leaflet in half, into two pieces. So you can see here we're basically still this is where we electrify the anterior leaflet. And now you can see it split into two pieces. So that when we go ahead and put a new valve in, you're creating a space here to allow blood to go through the LVOT. So this is on the left side, this is without the LAMPOON technique. On the right side, this is with the LAMPOON technique. So there are different iterations. I don't want to complicate it too much with the LAMPOON. The classical LAMPOON is what we call the retrograde, where we go from the aortic valve, through the left ventricle and retrogradely into the left atrium. The antegrade approach is where we go through the transseptal into the left atrium, and we do the same thing by puncturing through the anterior leaflet from the base. This is what we call a base-to-tip technique. One of the newer iterations is the tip-to-base laceration, and these are really helpful in patients like this patient who has a valve-in-valve or a ring, where you basically, it's a more simplified way of doing the LAMPOON. And when we pull back on this apparatus, the LAMPOON apparatus, having the ring or the valve will prevent the apparatus to come all the way and potentially injure the aortic valve. So we took this patient to our hybrid room. Remember, she's on ECMO. This is her intra-op TE, and you can see how this patient, I don't know how she's been surviving all of this. It's basically a pinhole opening of the mitral valve, a lot of pannus formation, and again, the mean gradient was 21. This is with a heart rate of 75. So after performing a transseptal puncture, we took a steerable sheath. This is a steerable sheath where we direct the sheath towards the mitral valve. And following that, we advanced the floppy wire through the mitral prosthesis into the ventricle. And the point is, we want to get this wire up through the aortic valve. So here you can see it's looped around in the ventricle. We got this floppy wire into the aorta. And you have a floppy Swan-Ganz catheter now advanced all the way into the aorta. Then we advance a snare from the arterial side. So the point is we're trying to snare the wire from the venous side into the arterial side. And then we advance this, we typically use an Astato 20 wire for these cases. So you can see here the wire was snared and retrieved into the GR4 catheter. And at that point, we created the veno-arterial loop. Following that, we performed what we call the flying V. This is the area where basically the laceration of the leaflet is going to happen. And the way we do it is basically we denude a small area of the wire. We remove basically the coating of the wire. Then we bend the wire at that location, basically giving it the shape of the V. And the back of the wire is then connected to a bovie, like electrosurgical pencil. So that once we're in position where we are across the valve, we basically electrify the wire that will facilitate lacerating the leaflet. So here, this is basically our setup right now. So you have the V configuration of the wire. across the anterior leaflet. We make it very careful and under fluoro, under TEE, that the position of this V wave is across the anterior leaflet. And once we're happy, we electrify the wire and pull on both sides, from the venous and arterial side, to lacerate the anterior leaflet. And then we confirm that by on TEE. Here you basically see the laceration involving the anterior leaflet of the prosthetic valve.
We're just a bit weary of time, Hussam, as well.
Okay. So following that, it's more standards. We dilate the septum, and then we advance that transcatheter delivery system into the mitral position. At that point, very slow inflation. It's unlike the aortic valve. We're very slow during this stage to make sure that we position the valve properly and accurately within the valve prosthesis. And this is the final result after the TE. You can see the mitral valve now clearly very nice opening. The gradient went down to 4. Remember, it was 21, 25 prior to that. And there was no evidence of any LVOT obstruction at the end of the procedures. Patient really did very well after this. She was decannulated from the ECMO. She was subsequently taken off dialysis and extubated, and eventually discharged to rehab facility. So this was a case of basically a complicated mitral prosthetic stenosis who underwent a successful transseptal mitral valve implantation. Basically, the transseptal mitral valve is the preferred option for patients who are high surgical risk. Always remember that LVOT obstruction is a serious complication following these procedures, and very meticulous screening is important to prevent such a complication. Thank you very much.
Thank you, Hussam. Beautiful talk. Thank you very we're just going to move on to the next speaker for time. I think we'll do the questions at the end, as we were told. So I'd like to invite Dr. Abdallah Omeish, bailout second TAVR implantation to treat device embolization. Very scary stuff.
Good morning, everybody. So my presentation today will be about the bailout second TAVI to treat device migration. This is an 80-year-old female who presented with worsening knee heart failure symptoms. She had hypertension, hypercholesterolemia, and diabetes on oral hypoglycemic agents. She's been stabilized on several medications. Her lab showed a normal or nearly normal creatinine and a hemoglobin of 11. She was in normal sinus rhythm with no interventricular conduction defect. Her transthoracic echo showed a severe aortic valve stenosis with a pressure gradient of max 90 and a mean of 50, an estimated area of 0.7 centimeter and ejection fraction of 60%, and a systolic PA pressure of 35. Her cath done early this year showed nearly normal coronaries, and her carotids showed scattered bilateral 20 to 30% plaques. Her Euroscore and SAS scores were calculated using online tools. She had an SAS score risk mortality of 4%, morbidity and mortality of 18. And as you can see that upon the heart team discussion, the patient was determined to be intermediate to high risk for surgical AVR, depending on the clinical judgment as well as the predictive scores. This is her CTA for the aortic annulus, which showed that the mean annulus diameter was like 23.2 millimeter. And this was reproduced upon calculating the perimeter to a derived value, which was also 23, and the area was 418 millimeter square. The LVOT diameter was also adequate, and these are the measurements of the sinus of Valsalva, the STJ, and the coronary ostia. Of note was that the left coronary artery was low at 9 millimeter. and the ascending aorta was 37 millimeter. The axis, both femorals were compatible with the 14 French integrated flex nav delivery system. And regarding the annular angle, it was 65, defining a horizontal aorta, making the device positioning and sealing more challenging. There was mild to moderate calcific aortic valve stenosis with main distribution around the right coronary cusp. So in considering her for TAVI, she was suitable for a 27 Portico trans heart valve from Abbott using a femoral access under monitored anesthesia care, which we call conscious anesthesia. This is a coplanar view, LAO-caudal, revealing the major distribution of calcium at the right coronary cusp. And this is a pre-dilatation, which is a default strategy when we deploy Portico valves using a 20 millimeter balloon advanced over a sapphire wire, not to exceed the minimum diameter of the annulus as measured by the CT. And we begin to deploy the transcatheter heart valve by turning the macro wheel in the direction of the arrow on the handle, which you can see here. This is the arrow here, in here. And we maintain the flush port at 12 o'clock for better commissural alignment. And you can see that the inner shaft marker band, which is here, this is the inner marker, was positioned at the same height as the distal part of the pigtail catheter in the non-coronary cusp. We start the release of the valve in a cusp overlay view at RAO-caudal 1044, aiming to achieve the implant depth of 2 to 4 millimeter. However, we thought that the valve went too much ventricular, especially on the left coronary cusp. So the valve was recaptured, and that was partial resheathing because the distal part of the valve was still below the annulus level. And then we again start releasing the valve, aiming for a better target implant depth, making every possible effort to achieve better coaxial alignment in such a horizontal aorta. Once we were at 90%, we continued the release very slowly to allow the pedals to detach at a time for subsequent full deployment of the valve. And this is the Portico valve. You can see here that we have 3 pedals in here. These 3 pedals, these are retention tabs on the outflow section of the prosthesis that facilitate the attachment of the valve struts to the delivery system. And the loader, while he is loading the valve, he makes sure that these tabs are retained and that they don't overlap with the struts in here. However, one of the retention tabs, which is the 3rd one, one of the retention tabs remain attached to the delivery system during the final deployment of the frame. And we immediately ensured that the macro wheel was completely turned clockwise, and we gently rotated the delivery system as usual, try to change the projection of the C-arm and avoid pulling and pushing. And finally, we got the 3rd pedal separated. And this is after separating the pedal, which was stuck, and that was the one. This is in the middle, the 3rd one in the middle. So angio after the full release revealed that the valve had popped out, most likely during the previous manipulation to free the last retention tab. The valve pivoted around the cusp, more on the non-coronary, more than on the left, and migrated towards the aortic side, resulting in severe acute paravalvular leak and shock. And one can appreciate here how the large cell geometry of the portico stent frame and the width of the sinus of Valsalva and the relatively short ceiling cuff of the portico prevent coronary occlusion in this case. All mitigated the risk of the occlusion of the coronary. Also, we should note how the calcium in the right coronary area, cusp area, how the calcium anchored the frame just above the right coronary cusp. Fast response because the patient's pressure dropped to 40 and maybe 30 and became desaturated, prompted the decision to take a second valve and advance that valve through the reverse migrated valve and deploy it in the native annulus. The key first step is to maintain a coaxial wire position to avoid flow obstruction from an inverted valve. This was unlikely in this case to have this valve, the first valve, inverted. However, if the aorta was wider and there was no horizontality for the ascending aorta, maybe it will invert, and in this case, the case would be surgical, will turn out to be surgical. So in a standard fashion, we aim to achieve an implant depth of 2 to 4 millimeter for the second valve. And this is a final aortogram showing grade 1 paravalvular leak that clears with each beat, with patent coronaries and adequate position of the second valve without extravasation or dissection to the ascending aorta. The patient restored stable hemodynamics rhythm and oxygen saturation thereafter. A mild PVL was confirmed with the transthoracic echo and invasive hemodynamics. The aortic regurg index was 30. The mean gradient dropped from 50 to 10 post-procedural. The patient was discharged on the third day post-TAVI without the need of any pacemaker. The transcatheter embolization and migration, which is the TVM of the TAVI, is rare, occurring in approximately 1% of the procedure, with even share 50% of aortic and ventricular embolization, and is associated with an increase in mortality and morbidity. It can lead to catastrophic consequences that occur despite meticulous planning and execution of the procedure. Embolization is manifested by complete departure of the transcatheter heart valve, in contrary to migration according to the VARC-3 definition. The spectrum of manifestations ranges from incidental finding on cardiac imaging upon follow-up to cardiogenic shock and severe acute PVL, like in our case. The TVM accounts for most emergent cardiac surgical indications during TAVI procedures. Some patients may have prohibitive operative risk, and percutaneous options are the only choice. Surgical conversion is usually required in all patients with TVM to the LV, whereas most aortic embolization are managed percutaneously. Knowledge of the retrieval tools and components of the retrieval toolbox, as well as techniques, are essential to the structural interventionalist. And you can see here types of snares, the gooseneck, the multi-snare and in-snares, and non-snare devices like those used by the interventional radiology and the GI people. The mechanisms of the TVM during TAVI in our case were the failure, in this case, the failure of the tabs to detach in such a self-expandable valve, and the second was the horizontal aorta. Reasons that lead to the valve malposition and implanting a second TAVI as a bailout include manipulation or post-dilatation, inappropriate fluoroscopic view during TAVI procedures, pacing failure, resuscitation, adverse aortic anatomy, like in this case, absence of calcification and self-expanding, and first-generation valves as compared to the balloon expandable valves, and the presence of bicuspid aortic valve. There have been several proposed algorithms to assist in determining the best approach.
1 minute, please.
Okay, 1 minute. For percutaneous rescue for the valve embolizations, but in general, if the embolization or migration is aortic, you go percutaneous management. If it is ventricular, you go surgical. And to maximize the safety of these maneuvers is crucial for the operator to ensure adequate anticoagulation, be comfortable with the retrieval techniques, and involve the surgical specialist within the case, and set a finite time to abort percutaneous attempts and convert to surgery. As was such in our case, the factors we talked about that contributed to the migration of the valve. Our case was life-threatening and required prompt intervention with a quick implantation of a second valve. If it was otherwise, it could have been treated in a semi-elective manner. The valve should have been snared, preferentially by the proximal tap at the inner wall of the aorta, pulled into the ascending aorta at a more desirable location, and a branch-free aortic segment. Holding of the first valve during the second valve passage prevents pushing of the first valve deep in the aortic root, and deployment of the second valve is done in the standard way. A valvuloplasty balloon could alternatively be inflated distal to the valve, and the valve could be pulled to a more secure location. Other retrieval tools can also be used to retract the valve, like snares and non-snare application. And to finalize, concerns of aortic dissection and injury, occlusion of side branches, and valve thrombosis remain there. Exclusion of the embolized leaflets with a covered or uncovered peripheral stents has been suggested, but may not be necessary, like in this case, because the addition of a second valve does not appear to have any hemodynamic consequences at follow-up. For ventricular embolization, surgical retrieval should be planned, and implanting a second valve in a proper annular position may bridge the patient while he waits for the definitive surgical procedure. And thank you very much.
Thank you very much, Dr. Abdullah, for this nice presentation. Yes, speaker.
Last speaker for this session, he will be Dr. Samir Mtour. He's a consultant, internal and cardiologist, head of internal medicine and cardiology department at Maqasid Hospital in Jerusalem, and he is associated professor at Al-Quds University, and he will talk about the suicide heart post-TAVI.
Assalamu alaikum. Hello, everybody. So suicide heart post-TAVI. We have in the past 3 years around 4 cases with suicide heart. First of all, we did not identify the entity. Hypotension following TAVI, it could be due to acute aortic insufficiency as a result of valvuloplasty. It could be LV dysfunction due to stunning myocard after rapid pacing. Could be due to pericardial effusion as a iatrogenic from the wire perforation or laceration of the aortic root, and arrhythmia, suicide ventricle due to hyperdynamic intraventricular obstruction after unloading by balloon valvuloplasty and TAVI. So why is it important? While uncommon is suggested by residual dynamic gradient, obstruction worse after premature beat and can be identified echocardiographically, it's important to differentiate from other causes of heart failure, as it will be aggravated by diuresis and positive inotropes, and can be effectively treated by volume expansion and negative inotropes. What happens? So complete or near complete outflow tract obstruction by ventricular angiography should be alert the operator to the likelihood of suicide ventricle physiology that may occur immediately after balloon valvuloplasty as the result of sudden reduction in ventricular afterload and hypertrophic obstructive cardiomyopathy-like physiology with increased outflow tract obstruction in the setting of afterload reduction. Pathophysiology. So after TAVI, the new valve instantaneously alleviates the fixed obstruction. As a result, the LV can eject more stroke volume. However, this can result in a chamber collapse and hemodynamic instability. The side ventricle, in particular patients with preserved to high ejection fraction with small LV and diastolic diameter, small LV mass, and high intraventricular septum to posterior wall thickness ratio are risk for this issue. Due to increased LV unloading, one may appreciate dynamic intraventricular gradient when severe LVH is combined with small LV cavity. This is the physiology we often see with SAM in hypertrophic obstructive cardiomyopathy. So what's the treatment? Patient exhibits suicide ventricle physiology should be treated with beta blockers and intravenous fluid, but not inotropes, because these may exacerbate the outflow tract obstruction and hypotension. In the ensuing days, 2 weeks, the outflow hypertrophy will regress in size and subvalvular gradient will diminish. So this is our patient. She is a lady, 79 years old, female, with diabetes mellitus, hypertension, and half-path, severe aortic stenosis, with estimated aortic valve area 0.3, with normal coronaries. So this is the gradient, this is the echo, and we can see here the maximum peak gradient is around 87, mean is 52, and the estimated aortic valve area is 0.3. So pre-operative, the peak-to-peak pressure was around 90 millimeter mercury. After, it was 10 millimeter mercury. TAVI was done with balloon valvuloplasty using balloon VAX 3 20/40, and Navitor 27 was implanted with good hemodynamic parameters. So this is the valvuloplasty. You can estimate here how it's heavily calcified. And this is the Navitor 27. In the supravalvular, we see there is no AI in this patient. So post-TAVI, her post-TAVI was complicated by hypotension and cardiogenic shock, echocardiography immediately done to rule out pericardial effusion or other causes that may cause hypotension for this lady. And she was transferred immediately to the ICU. She was diagnosed to have post-TAVI suicide heart. And you can see here in her echo the dagger sign. I think it's here better seen. It's more than 6 meters. Oh, I get back. It's more than 6 meters. First of all, they started with noradrenaline, and this is contraindicated in suicide heart because this may aggravate the situation. So we weaned the patient from the inotropes, and we started the fluid resuscitation with beta blockers for this patient. And she was improved, and a few weeks after she was in follow-up in my clinic, the gradient was less, and this is being described in the literature also. So it is today class 1 recommendation according to the ACC/AHA for patient undergoing TAVI to continue beta blockers. If they are not on beta blockers, so 24 hours they should substitute beta blocker for this patient. So take-home message is we should identify this entity, the suicide heart, and to treat appropriately and to avoid the inotropes in these patients and to maintain these patients on beta blockers or to start beta blockers. Thank you.
All right, so thank you very much. Dr. Mahmoud, we've got 5 minutes for questions, right? Can we have 15 minutes? Good, okay. So can I start with a question, and then I'll open it up to my panelists. Can I ask Dr. Abdel-Hakeem a question? Because you know, we don't often get cardiac surgeons, and we love to speak to cardiac surgeons. So as a humble cardiologist who wants to send you somebody for minimally invasive surgery, whether it's minimally invasive valve surgery or even coronary, what is the contraindication? Who should I not send to you for, or who would you think is not suitable for minimally invasive surgery?
I think now we don't have any, to say, absolute contraindication for minimally invasive cardiac surgery. I think it depends on the case and what we want to do in this patient. The only, I think, limitation now what we have is not in the valve, in the minimally invasive CABG, is patient with very severe COPD. We cannot make the single lung ventilation and harvest the lima. In the valve surgery, I think we don't really see absolute contraindication that the patient cannot be treated in the minimally invasive technique.
What about something that's unfavorable? So what do you think is going to make it very difficult or is not nice? Would obesity, female, anything specific that you think makes it more difficult?
We overcome this era to see this to say this patient is obese, this patient is female, the breasts are big or something like that. We have some technique to manage these things now.
I have a comment for your good lecture. I think it will be said it is minimally access, not minimally invasive, because the procedure in the open and the minimally invasive, as you said, it's the same. Only the approach to the surgery, just you do your access, you're opening the sternum. The second thing I want to add, the routes for this surgery, we have the traditional and the minimally mini sternotomy and the thoracotomy, small incision, and the other total laparoscopic valve surgery. And this is my comment. And my question to the tumors of the heart, benign, malignant, primary, secondary, what is the role of the minimally invasive heart surgery or valve surgery?
It's a question.
Mm-hmm.
It's a question.
Yes.
I didn't get it. Just myxoma, we do minimally invasive. In the left side or in the right atrium, we do minimally invasive tumor resection. But I think in the primary tumor or something like that, depend on the case, but I don't make any case of minimally invasive primary tumor resection.
Benign tumor, as you said, myxoma, is you think it is a fragile tissue and the complication may be worse and may going or shot to the brain, to the coronary, and we have much problem if it's not taking in a block the tumor, because it's very difficult. In the minimally invasive, you are fragmented the tumor, and it's very dangerous and the complication of the patient by this way. Yes, and I think the traditional is the best rule to do these tumors.
Yes, I think that are the cases, are rare cases to do, and depend on the case. Maybe you have to decide for this approach or this approach, definitively the safety of the patient to avoid any emboli more important than the approach, sure.
Thank you.
Dr. Abed, يعطيك العافية. I want just to thank Abed. It's not a question. Abed enters at Al-Maqasid Hospital, and he started the minimal invasive in our hospital. And there was a big fear that this may be really the outcomes will not be so good. We are proud of him because nowadays it's around 50 to 60% from the minimal invasive in our center. And we saw and we follow up these patients to be sure that these patients got a good surgical treatment and a good valve and a good technique, because we also thought that there is limitation in minimal invasive to good control for surgically, I mean technically, and it is excellent. All our patients, let's say 99% of our patients they could go home after 3 days, and that was amazing. Thank you.
Thank you.
يعطيك العافية دكتور عبيد. أنا بس بدي أشكرك دكتور عبيد. بلش بروجرام مينيمال انفيزيف في القدس في المقاصد من 2017 وإحنا لساتنا مكملين في هذا البروجرام. هذا البروجرام دخل كثير شغل منيح للمرضى وقديش أفرق هذا الموضوع. بس شكرا دكتور عبيد ويعطيك ألف عافية.
عفوا.
So my question is to Dr. Suradi. When you did the LAMPOON, in your case, you went antigradely, not retrogradely. Which is faster in such cases? Which is better? Because otherwise, it's a standard valve-in-valve procedure. But regarding the approach, the antigrade versus retrograde, when you choose this, when you choose that.
Correct. So, as I said, like, there are three types of LAMPOON. The antigrade, retrograde, these are what we call from base to tip laceration. So we lacerate from the base of the leaflet to the tip. The only time we would do the tip to base, which is technically it's not antigrade or retrograde. We basically go from the left atrium into the aorta and just pull back on the V wave, on the V wiring to lacerate the anterior leaflet. So the only time we use this if there's a prosthetic mitral valve in place or a ring, because you don't want to pull too much and then you can inadvertently lacerate the aortic valve.
Another question. What's your definition to an adequate laceration for the valve? Where by TEE, after you finish, you have to do it. Exactly. So what's your definition? When you are satisfied about the gap which is seen?
So you basically want to have the slit in the leaflet.
Yes.
That would be facing the LVOT. And the only way you can see that is on the TE, usually on the 3D. You need a 3D on-fast view to see exactly the slit in that leaflet. Otherwise, there's no really a specific measurement or anything like that.
Yeah, but how you sure would you be sure in that the slit is adequate and exactly at the site of the LVOT, facing the LVOT rather than somewhere else?
So before we do the
because that was a 160 area. You showed us it was 160 by
so
CT.
Basically we do it on fluoro. We position both catheters on fluoro. Usually we use the LAO caudal and then the REO straight view, and also TEE. We can see on 3D exactly where the catheter is facing in relation to the leaflet that we want to slit. Once we're happy with it, this is where we lacerate. It's a very cumbersome procedure. It's not really an easy procedure. It takes really time to be accurate where you want to slit.
Hussam, excellent, very impressive maneuvers you guys doing in the cath lab. My question to you, you admitted that this is a very cumbersome one, this LAMPOON one. Can you get benefit from a good surgeon who can help you just lacerate the leaflet and not be involved?
So this patient was clearly not surgical. We've had some patients, especially the ones we do with MAC, mitral annual calcification. We do hybrid approach where surgeon would access the heart through the left atrium, resect the anterior leaflet, and then we implant the Edwards valve through the left atrium.
Exactly.
We've had these cases. This patient, she had the prosthetic valve in place. It was not really a native leaflet.
So typically, if the patient goes for surgery, we need to go take all the whole valve and then would implant a new valve. But she was not really in any good shape to have this
Thank you.
surgical approach.
Can I ask a question to Samir? Samir, thank you for the nice case. Is Samir around? Samir, very nice case. With the suicide heart, and the patient is already on beta blockers, and he is bradycardic. And many of your patients will be already on beta blockers. What is the options you do? Just IV fluids?
It's just IV fluid, I think. It's
Okay.
just IV fluid. Second, I think these patients, I think, aortic valve stenosis, most of our practice and the cardiology, they don't give beta blockers because the stroke volume is low. So you need a little bit the patient to be tachycardic. So I think most of our patients with the aortic stenosis, they are not on beta blockers or low dose of beta blockers.
So I'll tell you my experience with Hussam patients who have a similar phenomenon of suicide heart. We give them phenylephrine if they could.
Yes, you can give
Phenylephrine,
Yeah,
and they do well.
Yep.
Yeah,
Yes.
and this works for suicide heart?
Yes, this works. Yes,
Okay,
this is
great.
described.
Thanks.
Thank you.
I think we're going to have to stop now because we've overrun our session. Thank you very much for the speakers, for the panelists, for my course chairman. I think we'll move on to the next one. Thank you.
شغال